Hello and welcome to the Doctor's Corner. I'm your host as always, Dr. Mark Pinsky, and today we have Tony Stigall from Space Coast Sleep Center with us. He's going to talk about sleep apnea and probably other related sleep disorders. So Tony, welcome to the show.
Thank you.
Thanks for being here. I almost said thanks for having me, but it's the other way around. He won't cut that out either, by the way. All right, so talk to me about sleep apnea a little bit. What defines sleep apnea?
Well, sleep apnea is when you stop breathing during your sleep for at least a period of 10 seconds or more. And there are different types of sleep apnea, with obstructive sleep apnea being the most common. There's also central sleep apnea as well as complex sleep apnea. So obstructive sleep apnea, what it means is that you stop breathing for a period of 10 seconds or more, and it's caused by a 90% obstruction in your upper airway. So the soft tissues included that we're talking about is the soft palate, the uvula, possibly your tonsils and adenoids if you still have them, and the base of the tongue. And central apneas are when you stop breathing for a period of 10 seconds, except there's no effort. So the brain fails to send a signal to the respiratory muscles to breathe. And complex sleep apnea is usually with somebody that's on a PAP device where they may not have had obstructive, or they may not have had central apnea, but due to getting PAP therapy, they develop central sleep apnea, and a lot of it is still really unknown why it happens.
So how would you even approach something like that?
Well, typically that person would have symptoms, and maybe they're tired during the day, they've got fatigue, some excessive daytime sleepiness, some insomnia, perhaps they snore. Somebody's probably witnessed this. They get up to go pee several times at night. They've got comorbidities such as hypertension, maybe type 2 diabetes, or some cardiac issues.
So you'd have to address those issues as well, not just, dealing with the apnea.
Well, if you don't deal with the apnea, what ends up happening over time is a lot of those things can be exacerbated.
Right. So what you're basically saying is you have to treat the whole thing, not just do, these individual things. They have to all be done as a group. So that's right up my alley, that holistic approach to how you do things. And I think it's one of the reasons why I send people to you. I've known Tony for, probably 20 years now.
Yeah.
We look good, but we're still old. But we know each other for a long time. Right. And I think I actually knew you when you were still a respiratory therapist, correct?
Right.
So you were a respiratory therapist in the hospital, and that's how we got to know each other. And then he branched out into the sleep world. And that's the Sleep Center is located here, and it'll be at the bottom of the screen so you can contact Tony directly. But it's located here in the Central Riviera area. And Tony's wealth of knowledge is so extensive because you've done it for such a long period of time. And what I love most is Tony and his staff, including his beautiful wife Jennifer, are really terrific about handling whatever we need them to handle as expeditiously as they can possibly do it. And so we pretty much use Tony's expertise and his wife's expertise to help us really take care of patients, almost exclusive to anything, unless if there's an insurance issue, but they do an amazing job. So we're grateful to have them so close by. All right, so let's talk about who gets sleep apnea. Okay, so I think there's a notion out there that if you're not obese, you can't get sleep apnea, right?
Yes, so that's a big misconception, and that could be probably the furthest thing from the truth. So with the obstructive sleep apnea, they estimate about 65 million people in the United States have it. And 85 to 90% of those people are undiagnosed. So a lot of people believe, as Mark said, is that only obese people get it. And that's not really true, because what really causes obstructive sleep apnea is the soft tissue in the back of your throat, or it could be that maybe you have a small jaw. So it's your anatomical features that really cause obstructive sleep apnea, like the base of the tongue, the soft palate, uvula, maybe you have a small jaw or a short neck. Right. So a lot of that is familial. So it's passed down from your family, from your parents. Your parents or your brothers and sisters may have had it too.
No, that's definitely true because in my case, as Tony knows, I have sleep apnea, and I'm not morbidly obese. So mine is clearly an anatomical thing. I've had myself totally evaluated, and it's related to, my upper airway for sure. I've got the deviated septum. I have a long uvula. I have tonsils that are a little bit enlarged, along with adenoids, and so that whole complex needs to be evaluated. I think personally, if anybody suspects that there might be an issue, so that's another thing that I often will talk to Tony about. I send patients to Tony on a regular basis, even if they're snoring, but nobody's ever noticed that there's apnea, but people are having other symptoms. So they're complaining about, oh my goodness, I feel terrible when I wake up in the morning. I just don't have any energy throughout the day. And if nobody's noticed anything through the night, I still send them because you'd be surprised about how many people turn up with existing sleep apnea. So let's talk about that a little bit. If sleep apnea is not diagnosed and left untreated, what are some of the complications that could arise from sleep apnea?
That's a good question. But before I go into that, I just want to tell you what sleep apnea does, so you have a better understanding. Sure. So what happens when we breathe? We breathe in air, which is about 21% oxygen. And when we exhale, we're exhaling carbon dioxide. So that's a normal process of ventilation. So when we sleep, our ventilation naturally decreases. But when we have sleep apnea, what happens is we stop breathing for periods of 10 seconds or more. And it could be dozens to 100 times in a night. And so when this occurs, what happens? We stop breathing. The carbon dioxide that we normally exhale is retained in the blood, and it causes an increase in the carbon dioxide, and so the blood becomes acidic. In addition, the blood oxygen level decreases. All right, so when this occurs, the chemoreceptors in the brain sense these changes in the blood, and your heart starts beating faster and harder. So your heart's beating faster and harder, your blood pressure is going up and down when you have these periods when you stop breathing during your sleep. When it's left untreated over time, you go on to develop things like high blood pressure. The heart starts beating faster. You could develop things like cardiac arrhythmias, atrial fibrillation, atrial flutter. It can lead to metabolic dysfunction, which in turn causes type 2 diabetes, insulin-resistant diabetes, mood disorders such as anxiety, depression, mood irritability, and things like that. So and the studies are also showing that the metabolic dysfunction also can cause things like Parkinson's and other organic brain syndromes like Alzheimer's. Right. So a lot of things, there's a lot of bad mojo that goes on with obstructive sleep apnea when you leave it untreated.
Well, and I think that the studies are clear, and I think that that's what's led insurance companies to say, okay, we're going to treat you now. And it's definitely led to what Medicare did. So they that's not usually an issue. We usually can get that stuff paid for one way or another. So that's part of what. Let's go there because I think that's always an issue with people, right? How does that whole process work? So they go to their primary care physician and they say, hey, listen, I think I'm having some type of sleep issue, some type of sleep. So I feel terrible in the morning. My wife says I'm snoring like a banshee. I need to definitely get evaluated. They go to their primary care physician and take it from there. What happens?
Sure. So the physician would send over a referral to the sleep center for a sleep study. And most insurances, private payers at least, require an authorization. And so what they look for when they review that referral is they want to see medical necessity. So they want to see that the person has symptoms of sleep apnea like snoring or witnessed apnea, or if they have hypertension or any type of cardiac arrhythmia. And as long as you show that, then usually they'll be approved for the sleep study. And then we're able to call them and schedule them and get them into the center. And if they do come back with obstructive sleep apnea, most of the time we are able to have them come in for CPAP titration. And
explain that.
Okay. So when we look at the sleep study, we were able to score it. So what we do is we count up the number of apneas and hypopneas that occurred during the night, and we were able to assign a score to it. So less than 5 events is normal. Between 5 and 15 is mild, and between 15 and 30 is moderate. Over 30 is severe. And then we also look at did they have hypoxemia, lack of oxygen in the blood, and so on. And generally, we're able to get them back into the sleep lab if they can demonstrate that they've had at least mild obstructive sleep apnea. If it's mild, Medicare requires that they have comorbidities like hypertension or excessive daytime sleepiness or insomnia, some type of symptom that qualifies them for CPAP titration.
Right. So let's go there, because I think that you touched on it, but there are differences between mild, moderate, and severe sleep apnea in terms of what treatments are available. So I think that people need to be aware of those two.
Sure. Well, there's different types of treatments because there are some people that are intolerant of CPAP. So some of the different treatment modalities that are available, number one could be weight loss. And what happens when we gain weight not only in our hips and our belly, but we also gain it in our face and our neck. And so when we lie down to sleep, that fatty tissue crowds our airway and it makes the collapse in the back of your throat worse. So when you lose weight and you get down to ideal body weight, which is like high school skinny, that can alleviate the apnea. Other options, you can try sleeping on your sides or with the head of the mattress at least 30 degrees or more. Other options, you can try the mandibular advancement devices. With those, you'd see a qualified dentist, and then what it is, it's a mouthpiece that pulls your jaw forward. You typically got to have 10 strong teeth in both the mandible and the maxilla. So some of the side effects of that, some people get temporal mandibular joint pain, and then other people over time, their teeth can become crooked, about 20% of the people. They also have tongue repositioning devices, and what those devices do is they just pull your tongue forward. Studies have shown that people prefer sleep better with the mandibular advancement devices when you match those two, when you put those two against each other. Other options, exercise. Let's see. There's surgical options. With those, you can visit an ear, nose, and throat surgeon, and they would do an upper airway examination to determine if surgery is the best route. So one of the more common procedures that they do is a uvulovalvular pharyngeoplasty, where they would remove part of the soft palate, the uvula, possibly your tonsils and adenoids if you still have them. And
not a very pleasant procedure, mind you. I'm just going to let you know that. Very, very painful. Very painful.
Yes, and plus
I didn't have it done, but I'm just telling you, I've seen enough of them to know.
It's got a 40% efficacy rate, so 60% of the people that have it, it doesn't do anything for them. So,
right.
And then there is a upper airway stimulation procedure that you can have done, where they would put electrodes on the hypoglossal nerve, and what it does is it stimulates the soft tissue in the oral pharynx. And so there's just not enough of those procedures that are done out there to really gauge the efficacy. So just more research needs to be done on it to be able to compare it to the other modalities that are out there.
Right.
And then last but not least, there's oropharyngeal exercises that you could do. I mean, with those, they're low risk and low cost. It's just your time. But studies have shown that when you do those exercises, that it can improve the obstructive sleep apnea.
I didn't know that. See, you learned something new.
Yeah.
I like that. I didn't know that. All right, so what's the difference between CPAP and BiPAP?
Okay, good question. CPAP is continuous positive airway pressure. So what that pressure does is it acts as a splint to keep your airway open to eliminate the snoring and obstructed breathing. And that's probably the most common PAP device that you see out on the market. And BiPAP is the same as CPAP, except that on inhalation, it also has that continuous positive airway pressure. But when you inhale, what it does is it gives you a boost on inhalation to augment breathing and make it easier to breathe. So with BiPAP, a lot of people that have COPD, they might find it hard to exhale and they have difficulty breathing on CPAP. But then when you give them BiPAP, it makes it a much better experience and they can tolerate it a lot better. And then, probably in the last 10 years, they've come out with what they call BiPAP ASV, which is a mode that they use for treating central sleep apnea, and it is fantastic. So what it does is it will treat the obstructive sleep apnea, and generally when it sees central apnea, it has an algorithm that monitors your breathing, and when you have these central apnea events where there's no effort, it breathes for you.
That is cool.
Yes.
I didn't know that.
Yes, and well, some of the studies have shown that people that have congestive heart failure, if they've got an ejection fraction less than 40, you shouldn't put them on BiPAP ASV. But in general, I can say that with my experience in the sleep lab and then following up with them in the clinics that we've had with our sleep specialists, a lot of the people that are on it that have central sleep apnea respond really well to it.
Okay, awesome. So what are the complications? What's the reasons why people don't do very well with CPAP?
Okay, good question there also. There's a lot of misconceptions. I know when I call people and tell them that they have obstructive sleep apnea, they're like, I'm not wearing that Darth Vader mask. I'm not putting that on my face. And those things are loud. My grandfather had one. And, one thing I can tell you is that the technology has improved tremendously.
Huge.
The machines, they're much smaller, quieter, they're sexy. And, the masks have improved as well, the interfaces. Right. So, but to answer your question, I would say the biggest reason that people don't use the device when they get home is the mask fit. So regardless of how well that device performs, if that mask doesn't fit right on their face, if it leaks, if it's uncomfortable, they're not going to use it, right. Period. It's going to sit in a closet. So that is the key to being able to use the device on a regular basis over time, is to make sure you find a mask that fits right and that you're going to be comfortable with. And then secondly, to make sure that you have the right pressure settings. And the devices themselves are not loud like they were 10 years ago.
No, they're quiet. That's the one universal, I will tell you. The patients always say, oh, my goodness, I couldn't believe how small that thing was, and I couldn't believe how quiet it was. And that's one of the other things I love about you and your people over there. They're very patient. Because it is very, very difficult to find. It's such an individual thing. It's sort of like when you go to a restaurant, the person sitting next to you hates his food. This person loves their food, and to get that right mask is tough sometimes. But you guys do an awesome job about getting people the mask that they truly need. So
thank you.
Let me say, all right, how do you clean the equipment now? There's multiple different ways now, right? You can clean.
Sure there is. I know that. When you watch TV during the day, they have commercials about the So Clean. Yeah. And those devices do a good job. They're expensive. They cost about $250 to $300. And I can tell you recently, one of the manufacturers, ResMed, they have come out and flat out said if you use those devices, it voids their warranty. And the reason for that, the So Clean uses ozone.
Ozone, yeah.
And what that ozone does is, what the manufacturer claims is that it ruins the integrity of the inside of the device. Yeah. And so they say if you use that, it's going to automatically void the warranty. So what are the alternatives? Hand wash them with warm soapy water. So you have the water tub that holds the water. Take it out, wash it with warm soapy water, rinse it out, let it air dry. You don't want to use a towel or a paper towel to dry it. If you do that, you get lint in there. It can cause a respiratory infection. So let it air dry. With the mask, wash it with warm soapy water, rinse it out, let it air dry. In the book, they recommend daily. But people that work, you might not have time to do it every day. So at least once, at a bare minimum, once a weekend. Wash it with warm soapy water, rinse them out, let them air dry. I would also recommend soaking them in vinegar and water. So you hand wash the humidifier tub, rinse it out, put it in a solution of white vinegar. 1 part white vinegar, 3 parts water. Let it soak for 30 minutes and rinse it out, let it air dry to get rid of the vinegar smell. Make sure you submerge the hose as well as your mask. And if you do those things, then you don't have to worry about mold, fungus, and bacteria. Because with the hose, it's just impossible to clean a 6-foot hose to get in the middle of it. Right. So just submerge it, let it soak in vinegar and water, and that kills everything.
Okay. All right. Now, how often do you really need to get new masks? Because people come in all the time and say, I haven't had a new mask in 10 years. Oh. I'm like, oh my God, that's pretty good.
Right.
But how often, roughly, do you think a person either needs to have one or they should have it checked to make sure that that's the appropriate mask for them?
That's a good question. Well, you have to realize that the masks, the seals themselves, are made out of silicone. And what happens over time, the oil of your skin breaks down the silicone and it gets soft, and then it starts to leak. And so if you wash it every day, that would preserve it and it'll last longer. But a lot of people don't do that. So at a minimum, you should replace them once a month. The insurance companies allow you to have, depending on the insurance company, they allow you to get a new mask a mask seal every month if you have like a nasal mask or nasal pillow every 2 weeks, and they will allow a new mask every 3 months.
Really?
Yes.
I didn't know that. That seems like a lot.
Well, the stuff, it does break down, and if you have higher pressures with a full face mask,
and it'll just leak all the time.
They leak, right? And then some people, they break them, and I've seen people break masks, and I wonder, how did you do that? How did you break that?
So they really. What about the need to get another sleep study? So when would that be an indication?
Well, if they have developed new symptoms, like if they start to have breakthrough snoring, or if maybe they start to develop excessive daytime sleepiness again, maybe labile hypertension, it's definitely time to consider a new sleep study.
Okay. And we've experienced that many times, you and I together. We can't close the show without talking about COVID. We got to talk about COVID,
right?
And because if you don't talk about COVID, it's not an authentic show,
right?
Of course, 20 years from now, it's not going to make a difference. But right now, so talk to us a little bit how, because I think that's a big concern in a lot of people's mind. Certainly people did not want to come in to see us when COVID first began, and now we have initiated and instituted all those guidelines that everybody says we should, and I do think we should. So tell us what you have done and Space Coast Sleep Center has done to try to ensure the safety of people during this crazy time.
Right. Well, what we've done is we try to screen people just when we talk to them. We want to make sure that they haven't traveled outside the United States within the last 30 days. And we try to ask them if they're sick, if they've had a fever, if they've been around anybody else that have had COVID-19 that they suspect may have had COVID-19. When they arrive, the techs meet them in the parking lot. We tell them to be there either 8:30 p.m. or 9:30 p.m. The techs will greet them in the parking lot, and the techs have on a mask and a face shield. They check their temperature. As long as their temperature is less than 100.3, we give them a cloth mask if they don't already have the mask, and we bring them back to the room and prepare them for the test. And so what we've done is we try to also collect all their paperwork prior to coming in and collect any copay just to mitigate any type of COVID-19 spread. Okay. And so far, we've been pretty successful at doing that.
Yeah, good. All right, good. Anything else that we didn't cover that you think we should cover that the audience will glean benefit from?
Sure. I know that people always ask, what is the cost of a sleep study? And I can tell you that if maybe you're self-pay, or even if you do have insurance, if you've got a plan that has a high deductible, it'd probably be best to call around, because when you go to the hospital, they do a great job, but people have to remember their charges are a lot higher. When you compare them to, like, let's say an individually owned sleep center that's owned by a physician or a freestanding facility. Mm-hmm. And so, for instance, like, let's say if you go to Center A and their reimbursement might be $1,000 and you have to pay 20%. 20% of $1,000 is $200. Let's say you go over to facility B and it's $600. That's $120. So that's a savings of $80. And if you have a high deductible, like let's say if you've got like a $5,000 deductible, you've got to pay that $1,000 versus $600 out of your pocket. Right. So it's best to just call around to see who can do it for you. They all do a good job in this area.
Okay. Anything else?
No, that's it.
Right. I think I will tell you that Tony and his people, again, are wonderful people. They do a tremendous job. And as you can see, Tony's a wealth of knowledge when it comes to sleep disorders, and he will gladly answer any questions when people come in and handle whatever issues that you have. He and his staff, they're again, just tremendous people. So we are grateful for your time, and thanks for coming in. I know you got to pick up your daughter from school, and so we appreciate you coming in. For Tony Stigall, who is the president, owner, whatever, of Space Coast Sleep Center, I'm Dr. Mark Pinsky. You've been watching The Doctor's Corner. This is Dr. Mark Pinsky once again, asking you to forward questions to us whether regarding this episode or any of our past episodes, at drmarkscorner@gmail.com. Also, don't forget to check us out on our website, pinskywellness.com or pinskyweightloss.com. We look forward to hearing all of your questions, and we'll get back to you as soon as we do. Y'all have a great week.